Yeah, they do differ, and it's a hot topic in paramedicine in particular, guidelines versus protocols. It's absurd to think that you can just memorise everything that you need to know. I mean, there's obviously some things that you need to know. You need to know how to be a paramedic in general, and need to know how to do life-saving things.
So if we can go from sort of overcalling it 9 out of 10 times to overcalling it 5 out of 10 times, then AI might have done good for us.
Couldn't agree more. I mean, it's a dangerous comment to make towards the end of a podcast with me. I'm not going to have a short answer to any question on AI, but yeah, I couldn't agree more.
I just wanted to start with laughing on the screen. I thought that was a great start.
Right. That's great. Shep, we've got another guest on. Prehospital Nerds podcast are back. And this week, we're very excited to have James Oswald here, clinical practice guideline specialist, registered paramedic, working with Ambulance Victoria. Why don't you tell us a bit about yourself, James, and why you love guidelines?
Yeah,
straight to it.
For better or worse, I live and breathe them. I've been a paramedic for a little under 15 years, worked in a range of metropolitan and rural locations, doing a few different things. And I've been involved in quality improvement or guideline development or education in one way, shape or form for round about 10 years, a little less than 10 years. Went to Monash originally for my undergrad with you, Alex. Then did a Masters of Public Health a few years later with a focus on research and on clinical policy, and our paths crossed again where you supervised some of my Master's research. So, small world.
Yes.
So that's part of my story, but I do live and breathe guidelines. It's sad to say, I guess. I used to redesign guidelines just for fun in my downtime because I just thought they could be better than the way that they were, and I guess I built up some capabilities or certainly a passionate interest in that regard. And then when I was on light duties after I knackered my shoulder, I had the opportunity to work with the guideline team, so I developed some more capabilities and more experience, and it stood me in good stead for when an expression of interest came up, and I was successful in applying, and we went from there.
Right, and now you're an internationally recognised CPG development and implementation specialist. I said that, you didn't say that.
Well, I am super excited. I think this is awesome. James, thank you very much for joining us on Pre-Hospital Nerds. I'm obviously a user of your guidelines that you've developed in conjunction with Ben and David, and I listen to the clinical conversations all the time, and we're very happy to have you on board today and share what you've done and how you've done it and developed and all that sort of stuff. I think it's really exciting, and we look forward to hopefully working with you a bit more in the future as well. But to get us started for today, mate, we talk about clinical guidelines. Simple question, what are guidelines? How do they differ to protocols?
Yeah, they do differ, and it's a hot topic in paramedicine in particular, guidelines versus protocols. Guidelines have a couple of different definitions. They're not really universally strictly defined, but all definitions share similar qualities, which are that they are systematically derived recommendations about clinical practice, and that they usually all share in their definition the fact that they're evidence-based or evidence-informed. But the really important part of it is that the process of taking the scientific evidence and the opinion goes through a systematic process to then spit out some recommendations about care. And when I say some recommendations about care, what people would tend to be familiar with is like really big peak body guideline recommendations that have these quite formal ways of speaking, like, in patients with hemorrhagic shock and a blood pressure less than 90, we recommend the use of crystalloid fluid, or whatever. Strong recommendation, weak evidence. So that they don't necessarily fill in all the gaps, but a guideline on, say, hemorrhagic shock might have 10 of these statements, 20 statements. The Predict guideline on paediatric head injury has like 50 or 60 of these kinds of statements. But they don't try to do it all. They are just a series of things that distill evidence into a practice recommendation. And a protocol differs from a guideline in that it does try to cover all the bases. Like, this is your one-stop algorithm for how to treat hemorrhagic shock. And it tends also to be more prescriptive. The way that we have traditionally used those two terms in paramedicine is that a protocol has to be followed and a guideline allows some flexibility in its interpretation. It tends to be that the way guidelines are written is that the way that they're written is that they permit flexibility. They don't try to do it all. They just offer these recommendations that any healthcare professional can come along and use to inform their practice. But inform the practice, not prescribe their practice.
Mm-hmm. Very good. Very good. I love it. Love it. Love it. Hey, Alex, what's your question? What are you thinking? I can see things going through your head all the time. You're just never ending on the other end.
It's look, I think that's a great overview, James, and good to sort of start off with a clear definition. And I think some of the words you mentioned in there would sort of allow the clinicians to realise, we've got room to move here. So I guess the sort of follow-up question, and you get this all the time, but do guidelines have to be followed? Or do you want people to read widely and justify their management based on a rare case report in an obscure journal or something in between?
Yeah, it's a controversial kind of question, especially in paramedicine, and it's going to differ depending on your employer, because guidelines are used. The term guideline is used variably for. I've just talked about, an international definition of guidelines, something the Stroke Foundation might use, World Health Organization might use. The way that the word guidelines is used in paramedicine, like for a jurisdictional ambulance service, slapping the word guideline on the book of what 20, 30 years ago would have been called protocols, it does differ somewhat. So if it depends which ambulance service or employer that you work for as to how you view them in that way, and how prescriptive they are, and what the terms of your employment are in terms of the variable, the way you can vary from them. I can speak. I start off with generalities and then speak a little bit to the Victorian experience, I guess. In general, our ARPA registration requires that we make informed and reasonable decisions. And you might say, informed by what, and what constitutes a reasonable decision? Well, scientific evidence, ethics, law, clinical risk, all of these are good things to start off with. And that is just way too much for an individual clinician to do themselves for every single topic. And so what guidelines, an ambulance service guideline in particular for us as a maker of guideline, what they offer, the paramedic who works for a jurisdictional ambulance service, is that they offer to do all of the heavy lifting for you. So the guideline maker will take legal advice. They will speak to scientific experts. They will synthesise scientific information. They will consider the risk in the context of the employer and the particular workforce, and then spit out a recommendation. So you can the heavy lifting of a justifiable decision is kind of done for you. Can you then vary from that? Well, like, nobody's going to stop you. There's not like a bunch of managers hiding around a corner that will jump out and say, "Oh, that's too much morphine." The question then is, because the question is it informed and is it reasonable? And it means, if you're varying from an established guideline, that the task of ensuring that it is a justifiable, informed, reasonable decision lays entirely with the individual. That's hard, because it's a whole thing to ensure that, and it's its own skill set. Early in someone's career, it's unlikely that they're in a position to do that. As experience and expertise develops, that is more common. And in fact, and then transitioning to the Victorian experience, it is something that we would expect and hope for our clinicians, that they that they vary from the guideline when it's something that's required for the patient. We like to say that the guidelines are appropriate for most patients most of the time. They can't be for all things all the time. We need the readers of the guidelines, the users of the guidelines, our paramedics, to know that and to use their experience and knowledge and all sorts of other points of reference to adapt the care to the care the patient needs.
That's a great answer. I really love the fact that the guidelines are adaptable, and like you said, I think a person's previous clinical experience can help make a decision as to what is appropriate if it's not currently in your guidelines. And obviously we need to be careful about people reading something from Martha's cookbook that says you can add 2 grams of sodium bicarbonate in mixed with something and it will produce a good outcome. So you need to obviously ensure that any information that you get is from a credible source and it's a peer-reviewed article or whatever. And I think nowadays we have a lot more access to those bits of information than what we did 25 years ago when I first joined the job. Is that, you know, our guidelines were delivered to us and the availability of research papers online like we have them now and free access to all this online medical education is far greater. So we're being exposed to more current practices that took a long time to get into our clinical guidelines than what they did in the past. And I'm sort of segueing across to the side here going, well, let's say I've got an idea about a guideline. How long do you think it actually takes for somebody to start producing some research and doing something about a particular practice for it to then end up in our clinical guidelines?
It varies immensely. So traditionally, the evidence to practice gap is huge, years and years and years. I think like
17.
17 is, yeah, it's a bigger figure than I've heard. I can think of some topics where it would be 17 years. I've heard like 7 to 10 years. I guess it just depends on the topic, but it is traditionally like it's huge.
Yeah, it's probably heading towards sort of 7 or 10 years, and with all the stuff you're doing with sort of, you know, having online CPGs and apps and pushing updates all the time, that's certainly going a huge way towards getting this stuff out. But now people have researched this sort of empirically, how long from when an intervention's determined as critical to it becomes widespread practice. And like aspirin for acute coronary syndrome, 17 years from when they sort of signed that off. That's a good idea to when that was standard of care. So,
lung protective ventilation was another one. I think we ended up with a sort of 10-ish year gap between some of the original ARDS and studies and changes in practice. It takes a long time.
So what do you do?
So we are absolutely. Yeah, that's a good question. Like, how do you deal with that? The standard in guideline development is that peak body guidelines are reviewed every 5 years, and that's a long time. It's not the only contributor to the evidence practice gap. It's part of it. In general, in the guideline world, people are moving towards living documents, so they evolve at a faster rate. I think ours have been living documents for quite a while, especially since we went primarily digital in 2019. The updates happen in a much more timely way. It really depends a lot on the topic. There have been instances during COVID where the entire system is totally focused on one topic, and everything that needs to change can change at the drop of the hat because nobody is doing anything else except that thing. And so it took us, in some instances, days to translate evidence into practice change. But that comes at a cost because you can only do that on one topic and only for so long.
Yeah.
You can only maintain that cadence for so long. And the rate of change and confusion and chaos that tends to cause is also a problem. But then what's the optimum? How often does change occur in order to be timely and to reflect the changing evidence base, but also not overwhelm people with too much evidence? I mean, if you've got the answer to that, I'd love to hear it, because I'm not sure I know that yet. We've been trying to find a happy medium that is not too much for people, and it is a common point of feedback from a lot of different workforces in Australia, ours in Victoria as well, that change occurs too frequently, and I accept that. It is hard. There's only so much change humans can tolerate, you know. So, but at the same time, the science is also changing, and if we know we can do better by patients, we need to. The happy medium is hard to strike, but we're definitely trying.
Every 1,000 days. 3 years. I reckon, because then every sort of wave of undergrads that comes through would bring forward the latest updates. But yeah, cool. Hey, just yeah. So you're saying international peak guidelines sort of update every 5 year.
Traditionally, most people have moved to more living documents.
Yeah. And that's why the CPGs are more and more living, and most states would have sort of online CPGs, and there'll be small updates trickling out there, sort of on a weekly, monthly basis, or is this a big announcement when there's a change?
It varies a lot by state. I spoke to a bunch of the guideline developers at different states recently. We talk all the time. We've got a pretty good community practice. We know each other fairly well. And it varies a lot. Some will launch relatively minor updates on an almost monthly or just as required basis, and keep more complex or higher impact changes to a less regular cadence. Sometimes that's twice a year, sometimes it's once a year. It varies a lot. We in Victoria have most recently found a bit of a happy place with one major update per year, with another 1 to 3 moderate updates on an as required basis, and very, very minor updates. I'm talking like typos and feature changes in the app that nobody will particularly notice, but that improves the underlying quality of the app just on an as required basis. Like, people wouldn't even notice when we make those updates. But I think for the stuff people notice, one big one and 1 to 3 mid-sized ones, small to mid-sized ones per year seems to be a reasonable place. But I think that'll just evolve over time.
Yeah. I didn't mention at the start, but how excited I was about you coming on, that I did put on my shirt and dressed up for the occasion. So thanks for coming on. I'm lifting the standard on Prehospital Nerds. Now, one good thing that
I have your t-shirts on.
Well, we're going to get one signed for you, mate. I think we'll get you an original one, and we expect you to wear it on one of your clinical conversations. That'd be great.
Here it is. You can order it in the link below.
It's guaranteed. I will wear it in the next episode.
Now, guidelines do change a lot, as we've just been talking about there, and as a user, we do see an awful lot of change, and it is really hard to keep up, but I think it's a very good change. And certainly within our state, one of the big things that has been pushed is that you don't need to memorise the whole guideline like we used to in the past. There was the expectation that I could point to any page in a book and recite part of the guideline to you, and clearly we've evolved way past that, and I feel that that's a really good step forward in paramedic practice, to recognise that if you're across something that you haven't seen, or it's the first time you've come across it, a safe way of practice is to actually pause and stop and check with the book and check with the guideline. And I certainly know back in my nursing days many, many moons ago, is that if we were doing an infusion for a patient, there would be 2 nurses at the end of the bed checking with a clinical practice book to confirm that the medications that we were given were the accurate ones and it was appropriate for the patient, and there were no contraindications. So I think the evolution of the app is fantastic, and the push now for the education that, if you come across something that you're not familiar with, that you open up the app and you actually check and confirm with it. So that's a great move forward, I think, with what we're actually doing there.
Yeah, it's a really important part of the message we want to communicate to paramedics in Victoria. And I think for paramedicine in general, it's absurd to think that you can just memorise everything that you need to know. There's obviously some things that you need to know. You need to know how to be a paramedic in general, and need to know how to do life-saving things, with the addition of checking critical facts, medication doses or what have you. But the way that I describe it is that we want understanding of the guidelines, and the facts you can look up later. When I speak to the graduates at the start, on day one, literally on day one, and I walk through a head injury guideline, a patella guideline. I wrote these guidelines, but I don't remember the list of risk factors for what puts a person, strictly speaking, in moderate or low risk or whatever. And you don't need to.
Yeah.
Just broadly speaking, if you know the guideline exists, you know the gist of it, you understand what it is trying to achieve, and you want to look up one or two little details just to double check the facts later. That's the optimum.
Yeah, and I think that's a great way of going, because there are certain cases and clinical presentations that we come across day in, day out, and I think people's experience and exposure to those creates a good understanding and a knowledge of that guideline. But it's those rarer cases that you actually come across that you go, oh, hang on, I haven't done this in a long time. Let's go back to the book and just confirm. Obviously, your commute to the job, if the data terminal provides you with accurate information, then you can check up on that and you can confirm with the guideline on the way. I know in the helicopter, we've got 30 minutes to look at my guideline, so I actually look smart when I get out at the other end, but none of it's true. So you get a lot of time to actually have a look and focus on your guidelines beforehand, and I would recommend all clinicians do that as a practice, that, you know, data that is available on the data terminal or is given to you over the radio, think about how you can apply that with the guideline that you're actually using, and then bring that when you arrive at scene. So it's fresh at the front of your mind, I think is a really good way to go.
Yeah. And just on that point, if I could add, like when I was at Monash a few years ago, sort of taking a cohort of undergrads, I had to come up with a big change. That was sort of part of it. You got to come up with a big change. So I asked the students, do you want to have access to the guideline in the exam? They couldn't believe it. You know, traditionally it was like, you know, that's what you're being assessed on. They didn't understand the question, but and I said, no, just, you know, in your prac exam, just have the guidelines available. And it got endorsed, and now that's standard of practice. And the guideline, they can't use their own phone for whatever Monash Uni exam sort of requirements, but there's an iPad there with the guidelines. So hopefully that can sort of be reflected on road, that the cohorts coming through, they're in the practice of double checking all the GTN doses, because some go and some get added and some rare drugs get introduced, and like, you know, why are you going to memorize this? Just double check it every time, and then as soon as there's an update, you have it ready at hand.
Yeah, couldn't agree more.
Good. Now, where are we going to go next? There's so much to talk about. What are some of the challenges with guidelines, and probably sort of using them, and without leading the question, is it a problem that it sort of can be a bit binary, in that if the blood pressure is less than this, do this, or if the, you know, is that a problem? Like, the alternative would just be to have a generic test, like a generic sort of text, and say, if you think the patient's shocked, maybe give some fluids, give some presses, whatever. The alternative to that is, say, blood pressure less than 90, noradrenaline, IVT, you know, this sort of stuff. So is it reductive, or is it...
Yeah, I know what you're saying. It is a constant challenge in how to write the guidelines.
Yeah.
Because medical and academic writing, medical writing in particular, has really got form for being vague, and I feel like that is you know, to be a bit charitable, that it's trying to reflect the grey and the flexibility that they want, and that is the reality of clinical practice. But that vagueness means that the audience frequently doesn't know. It doesn't offer anything to the audience. You don't know what you're being asked to do. You've gone there for answers, and you didn't get any. The other end of the spectrum, then, the reaction to that is to provide more information, you know, more precision of information. So you don't say if they're shocked or if they're hypertensive. You give a blood pressure less than 90. What that then risks, and the tension that we have, is this pendulum swinging between people saying, I don't know what I'm being asked to do. It's too vague. To, why are you creating all of these inflexible rules for me? It's too prescriptive. So if you say less than 90, but you know the blood pressure's 95, but they have cold peripheries and blah blah blah, are they still shocked? But I can't give fluid because it's, you know, it says 90 in the book, and you know the score. That is a constant tension, and I think the ideal state is being able to provide more precise language with the understanding being that the precision is to give you clarity on what the recommendation is, but it is precision, not prescription. It's not there to create a series of rules for you that you must follow just because the information is specific. The specificity is about clarity. It's just trying to make the recommendation clearer, but it remains a recommendation that you can change up depending on what the patient needs. We talk about two kinds of information being in the guidelines that we write. One is directly actionable information, like a medication dose, like that's a no-brainer. Obviously, you need that kind of information. The other part that's harder and kind of relates to that question is material context. Information that directly informs the use of the actionable information, and without which you couldn't really reasonably be expected to use the actionable information. And so the example that I give sometimes is that a lot of more flexible language is also very relative. So it might say something like aggressive fluid resuscitation. Well, what is aggressive if you lack a point of reference? If you're not doing this all day, every day for trauma patients or something, then you don't have an experiential point of reference. So what does aggressive mean? But also if you say a particular amount, well, then that locks a person in to a particular amount. It doesn't give them any flexibility. So what we try to do increasingly is give is the main recommendation as a flexible concept, i.e. aggressive fluid resuscitation, but then give as an example a more objective point of reference. So you might say aggressively fluid resuscitate the patient. That's the recommendation. For example, in excess of 2 litres or whatever, just so you've got, so you have some more objective point of reference. So you're talking about 10 mils, you're talking about 500 mils, you're talking about 50 litres, like you need some kind of point of reference. And so yeah, I think the answer to that question is we do need to write good guidelines that are precise in their language and careful in their language and intentional in their language, that retain the flexibility that is required for clinical practice, but offers people usable points of reference so that they are still practical resources that inform clinical judgment. It's easier said than done.
Well, I think you've made a good step in the right direction with it. When you look at our guidelines from years ago, and it was a page with a guideline and nothing else, whereas now you have a guideline with the explanatory stuff and the links to the MAC papers and so forth. So the medical advisory committee that actually review all of the papers that put together the guidelines, so that the person who then reads it can then go, I actually now have a really good understanding why this is all put together. So that, and then in combination with things like videos and so forth that's been added to the Victorian guidelines, I think that creates a better understanding for all users. It's expanse, it's much bigger than what it was before, but at least the information is easily accessible. One thing I want to know, so it's not just you, David and Ben, that sit down and put these guidelines together. There's a multitude of people that actually create a guideline. How many people are actually involved in generating a guideline?
Yeah, lots is the short answer. So a good way of developing any guideline is to have a core group of people who lead the effort, a sort of a project manager, a lead, a methodologist, or a writer, or whatever. At Ambulance Victoria, it's the guideline team. So it's a couple of people like me whose full-time job it is to coordinate these processes. But it isn't just those people sitting down and saying, gee, I know a lot about asthma. I'll write what I know about asthma down on a page and that will be the guideline. 20 years ago, 30 years ago, a lot of guidelines were that good old boys, sitting in a room. It's certainly not that. It hasn't been that for a long time in a lot of ambulance services. So what I do is really more a process of coordination of different sources and voices and people rather than me writing what I think. Yep. To give you a more practical answer, so there's a couple of people in the guideline team, but there's then a clinical practice guideline committee that involves representation from the operational workforces, half a dozen paramedics involved. There's representatives from different parts of the organisation that are relevant, people like equipment or pharmacy and so forth. That committee's 20 or so people big.
Okay. Yep.
Then now called Peak Clinical Committee, was Medical Advisory Committee for a while. It is 15 or so people, a combination of senior leaders at Ambulance Victoria and medical advisors. And the Executive Best Care Committee of around about 10 people is another relevant committee that signs off the implementation of those guidelines. And then there's a really variable number of people's voices that we draw onto as part of the consultation process. So we consult specific subject matter experts. It can vary from one person, depends on the topic, one person to 5 or 10 people.
Yep.
And we also are very keen to hear feedback from the users of the guidelines. So we tend to post drafts on our internal social media site, Viva Engage, for those of you listening from Ambulance Victoria, and that's a really important mechanism for getting feedback, because you've been sitting there looking at Guideline for a couple of weeks, and does it make sense to you? It may not make sense to the people who have to, who actually have to use it. I mean, I do have to use them, but you know what I mean, to the broader end user base. So if you ever get an opportunity to, as an Ambulance Victoria employee, to feedback on guidelines via those mechanisms, it doesn't get printed out and then chucked into the shredder. That really matters to us, and it very often leads to really significant changes in the way the guidelines are structured. It's really important. So there's what does that add up to? I mean, anywhere between like 30 and 50 people involved in the guideline.
That's impressive. I've got another one for you. Alex, I'm going to keep you quiet here for a tick. What's a guideline that's been produced that you've gone, oh crap, that one wasn't probably delivered the best way that we wanted it, or it's been poorly understood by everybody, or let's rewrite it and start again?
Oh, that's an excellent question. How long you got?
That'd be a first, actually.
I think the best example is probably a best recent example is probably the acute behavioural disturbance guideline. We included in one of the iterations of that a couple of years ago a sedation scale, and we felt that attaching SAT scores to particular agents would be an easy shorthand way of saying, roughly speaking, a SAT score of 1 equals a less invasive or significant sedative, olanzapine in our case. A SAT score of 2 equals another agent. A SAT score of 3 equals ketamine. And it was intended to be an approximate guide, a sort of a thought experiment, because the letter of the law, literal definitions of those categories are pretty easy to fit into if you only look at the exact words in the table. The intent was that you pair the descriptions in that table with a broader understanding of the risk and level of agitation and disturbance that the patient's experiencing. To give a more practical example, I think I haven't got the table in front of me, but I think at a fairly high level of SAT score, it's got things like verbal outbursts. So if you're quite literal about that, I mean, I stood on a piece of Lego this morning and I had a verbal outburst.
Ketamine.
I didn't need ketamine. And so this created a bit of a problem in that related to what you're saying before. If we give people really specific, precise pieces of information that we don't want to be prescriptive, but we do want them to be sort of actionable and simple and memorable. Like, as a rough rule of thumb, SAT 1 equals this, SAT 2 equals this, SAT 3 equals this. I think that created the wrong impression. And so we ended up with instances in the education that went around that where, quite rightly, the education, the people involved in the education had written scenarios that were true to the black and white definitions of those categories, but misrepresented the intent. And we learned over time that patients were getting invasive sedatives or excessively restrictive sedatives, things like ketamine or droperidol, in instances where we didn't intend to be for patients to receive those medicines. And so, in wanting to revise that, we did a bunch of things after a pretty significant review of that guideline. But we decoupled the SAT scores from the agent.
Yep.
And hopefully moved away from the false impression that we had created. It's not the audience's fault. This is very much a problem we created by implying that the score mandated the agent. And now that we've decoupled those and made it clearer that there is more nuance and judgment to be had there, the guideline is better. And
Excellent.
we've seen a great improvement in the right agent being matched to the right patient.
So the SAT score, I better just explain for those that aren't aware of it, is the sedation assessment tool that was developed for using the appropriate sedation for a mental health patient or an agitated patient of any sort. And obviously the higher number meant that we would be using a stronger medication to take control of the patient. I had something I was going to say which was really, really good then, but it's completely gone from my mind. So talking about fixing that, one of the big things that came out throughout the ambulance service was a strong push within Ambulance Victoria. It was a strong push then about if you're going to sedate, plan to resuscitate, so prepare yourself. So if you're going to give a person copious amounts of sedation, you need to set up your equipment beforehand. So I think that may have also helped, because clinicians then go, actually, before I step in and start giving lots of sedation to patients, we need to ensure we've got everything set up and ready to go should we have any complications. So that was a great outcome really from that guideline. So even though you feel as though it may not have been great, it maybe had a few instances where things didn't go as well, but I feel that we've turned the corner with it and improving the way we manage those patients at the moment.
Good topic for a podcast at another time.
Oh yeah, there you go.
We'll schedule it in.
Yeah.
Yes. I've got one for you, James. So, the benefit of guidelines is, and I've heard you talk about this before, the sort of when to escalate care, because I think that individual clinicians might sort of think, no, we got this under control, but and I'm just reflecting on sort of how it works in ED, someone has a fall, they got some rib fractures. If it's 1 or 2, they go home, maybe a night in short stay with some pain relief. But if it's 3, if they hit that magic 3, bang, up to ICU, anaesthetics get involved, acute pain service. So it's just an automatic trigger, and there'll be people with 4 rib fractures that don't need ICU and stuff, and probably there are people with 2 that could benefit from some more input. But having a line in the sand that's saying, once a thing crosses this threshold, get some other people involved, and be no different in sort of pre-hospital guidelines. If you go to someone with SVT, if the blood pressure is less than 90, they might probably do well and Valsalva and stuff, but just pick up the phone and see if there's someone with adenosine available. And so I don't know if you had some thoughts around the sort of the role CPGs have in governing escalation of care.
Yeah, it's the perfect topic to tease out when a protocol versus a guideline is useful, because in the huge majority of circumstances, I think guidelines that allow and encourage judgment is the best thing for patients and clinicians. And where you flip that on its head is escalation of care, because mandating escalation at certain points, you can talk forever about what those points are and what the tools are that you use to create triggers. It's a whole different conversation that I very much enjoy. But whatever those triggers are, mandating escalation at those points takes out human fallibility. And that then really tends to become a question for organisations and institutions to decide what risk threshold they are content with, because risk pretty much always exists on a spectrum, right? Like nothing magic happens at a heart rate of 140 as opposed to 141 or 139, but you draw the line somewhere. It's generally for organisations to decide where the inflection point is for them to say, you know what, at the clinical judgment was maybe okay with a mild tachycardia, but at a certain point, enough of these patients are going to be critically ill that we simply cannot tolerate people saying, nah, it's fine, because they'll be wrong a percentage of the time. And some of those patients will probably experience really bad outcomes. So we accept as an organisation that we will push the big red button on 100 patients who meet this threshold, and 92 of them will be okay. The system will have to absorb that, and that's a question for the institution or whatever to know how much they can over triage they can absorb. And it's frustrating for the individual clinician, because it's very possible that you see 13 or 14 or 50 patients in a row who are the patients who are fine and not the 8 patients who weren't. But at the systems level, it becomes much easier. In the role that I do, it does become much easier to see the 8 patients who weren't, and to see those patients now get the escalation of care where they didn't before the escalation system came in, and they have good outcomes. And the 92 patients who were, broadly speaking, fine, have an intensive care paramedic or a intensivist in the hospital environment pop around and say, I've had a bit of a think about it. I think you're right. I think you're good. Job done. You did the right thing calling. I've had a think about it. And that's the system. That is the system working. It's kind of the inverse of the idea around clinical practice guidelines. It's the permission to call is a really important part of that. That it takes out the it takes out the judgment from the fact that more often than not, when you push the big red button on escalation of care, the patient is fine. But we expect that, and so you don't get the interpersonal effects that come from that. You don't get the sort of cranky intensivist or the cranky paramedic saying, "Why'd you call? This patient's fine," because we have all collectively, as an organisation, accepted a certain rate of over triage to make sure that those 8 out of 100 or 12 out of 100 or whatever patients who do turn out to be critically ill get the right care.
Absolutely, I agree wholeheartedly. I see it in practice, obviously, all the time. And crews are very apologetic when they go, I feel that we're okay with this patient, but the guidelines sort of dictate to me that I need to escalate care. And more often than not, most of the times, they've done a fantastic job. When you arrive at the patient, they've managed their patient appropriately, they've recognised the patient being unwell, and they've called you appropriately. But then, the intervention that is actually required may be minimal or nil, and you'll be able to continue them on with transport on the way. I think, patient review teams within Ambulance Victoria has obviously helped dictate where these escalation of care guidelines have actually come in, because we've had numerous cases in the past where we look at stuff and we go, we could have done a lot better at this job, and we could have recognised these things a lot earlier. And when you get a lot of those cases happening in succession, it's quite easy to go, well, at this point, with these vital signs, this is a really clear indication of a patient who is going to deteriorate. So how about we put something in play that will protect these patients by organising the first crew to escalate that patient straight away. So I think it's a great way of doing it. And I understand people get frustrated by it sometimes, but I think for a safety perspective, it's a very mature way that we manage our guidelines. So well done on that. That's terrific. I noticed the time. We're up to 45 minutes already. We could go for hours.
Yeah. Well, we could continue on this and schedule another time for... Because you've got lots to talk about, James. We're going to have you back for another one.
I never have any shortage of things to talk about. You can split, like you do 20-minute kind of format, right? So you could split it into 2 episodes, I guess.
Yeah, absolutely.
To do it, get a little bit more content, because that's what we're up to, probably about 40 minutes of actual content.
Yeah. And then the other thing is...
do one more question or something and make it 2 episodes.
because we've got to get your dislocation stuff in as well. I noticed 12:30 will be looming very quickly. So how about we throw in a couple of quick questions and then finish off?
Can I just tack on something on the thing we just spoke about, and then we flow on from there?
Sure.
Yeah, good. So this is a fascinating discussion, and we're talking about where's the line in the sand, and you're mentioning, James, sort of 10 patients out of 100 above this will do worse. I know you've got a keen interest in AI and machine learning, and of course that's sort of where it's a prime time for that, because at the moment we're saying, supraventricular tachycardia with the blood pressure less than 90, pick up the phone. But if you could factor in past history, link it in with the My Health record, what medications are they on, age, sex, gender, 100 variables, you're going to get a much more sort of accurate answer to say who needs some backup and who's probably going to be fine. So if we can go from sort of overcalling it 9 out of 10 times to overcalling it 5 out of 10 times, then AI might have done good for us.
I couldn't agree more. I mean, it's a dangerous comment to make towards the end of a podcast with me. I'm not going to have a short answer to any question on AI, but yeah, I couldn't agree more. We currently we traditionally made a decision on one piece of information. Blood pressure less than, call. Heart rate greater than, call. We've moved increasingly towards a multivariable escalation of care mechanism, or we don't use it for escalation of care at the moment, but I'm talking about news too. To risk stratify, to determine risk in patients with infection, and I suspect we'll probably move to using it or something like it for escalation of care as well. But that's still, 20 years ago stuff. That's moving from one piece of information to 10 pieces of information, and what I'm interested in is using hundreds of thousands of pieces of information in real time, and that means AI. Very keen to see that work. I spent you know this, Alex. So for others' benefit, I spent a Sunday morning recreating a machine learning approach using some dummy ambulance case sheet data to use to create a predictive tool for deterioration. It's right there. It's ready to go. Someone just needs to do it. It was I could do it on a Sunday morning. We just need the expertise to make it work well.
Yeah.
The Prehospital Nerds AI app.
Yeah, that's right. Watch this space.
That's it. Oh, very good.
Any other questions, Shep?
No, look, I think we've punched through an awful lot of information here, and I know that James is a busy man, so we'll cut this one off for the moment, and my intention is that we would definitely, if James is willing to have you back on the show at another date, mate, that would be wonderful if you could. So thank you on behalf of Pre-Hospital Nerds, thank you for your time, and thank you for clearing up some of the information around the development of clinical practice guidelines, and thank you very much, and we'll chat again soon.
Thanks for having me. I love what you're doing with Pre-Hospital Nerds, and I can't wait to chat again soon.
Good on you. Thank you.
Great.